Thank you very much, Amjad, for the introduction.
Can you see the slides?
Yes, I've got. So if we could just go to the first slide.
Yeah. Let me do that. And is that's okay. Yeah.
Amjad,
Yeah.
can you make it in presentation mode, please?
So the aim of this guidance is to. So thanks for the opportunity, everyone, to speak this morning. The aim of this guidance is to outline areas that we as Global Fund see as high investment priorities. To emphasize how those investments can be optimized at a time of very constrained funding, to make sure that those investments get to the people who need them most, and to do that in a way that's evidence-based and is going to support the achievement of impact, which ultimately is the overarching aim of what the Global Fund is trying to do. Next slide, please. So hopefully this is useful for those of you that are involved with helping countries to produce guidance and involved with DCMs and involved in the process. But really, the process this year is really looking towards these eight priorities when it comes to HIV. A lot of this isn't really new. It'll be an extension of things you've already heard and things that you already know, and indeed things that you're already working to achieve. But for prevention, we're really the focus is really around efficient and effective prevention that is able to reach the people who need the services the most, people with highest incidence. The resources are limited, and people's needs do vary a lot. With testing, really a focus is around making sure that testing strategies are fit and appropriate for this stage of the epidemic. We know that we've seen testing, positivity decline progressively year on year, but there are strategies like partner notification, like social network testing, that can still be really effective in helping to identify people with undiagnosed disease. Testing here, we continue to support integrated testing of women in the prenatal period for HIV, syphilis, and hepatitis B. So that continues despite all the challenges and constraints at the moment. I think for treatment, I think one thing that's really clear is treatment has not, the global community has not yet succeeded in getting and reaching high treatment coverage in all countries, and indeed among all populations within countries. And, when we look at even some concentrated epidemics, where the epidemic is driven by key and vulnerable populations, still those key and vulnerable populations face disproportionate barriers leading to problems in getting access to ART. I think the other thing that we are going to try to support countries on more for this cycle is around advanced HIV disease and really addressing mortality from HIV. So mortality has not declined, to the extent and as fast as it should. And, that is a key part of what we are all trying to achieve in the HIV response. So integration, you will see mentioned throughout the guidance, not just as a means of achieving greater efficiency at a time of funding constraint, but also as a means of being more person-centered and being more effective. Noting that we have to be careful that as services for specific populations become integrated into primary care, that we maintain the things that made those services, or that countries maintain the things that make those services accessible in the first place. So access barriers. So you'll be very familiar with this. This continues to be a key consideration of Global Fund in terms of the support it gives to countries and the way it looks at funding requests. But of course, in the HIV team, we fundamentally, understand and appreciate the need to address the disproportionate barriers that exist often for the very people who have the most need for those services. So this all is something as ever to be delivered through partnerships, both through international partnerships at the local level, obviously leveraging community systems to achieve this, to ensure that the people who need the services can reach them. And a last point here on decision making, which hopefully can be a useful thing to do in mind during some of your deliberations and consultations that many of you will be having with CCMs. But with less money, there is an onus on us to be even more robust in terms of how we look at the use of evidence in terms of the extent to which difficult choices are made on the basis of data that's going to make sure that those limited resources get to where they will have the most potential to benefit the people who need them. Last slide. So this next slide is the last slide I'll speak to, but very happy to obviously join for the Q&A and looking forward to some really interesting discussion there. This is just to say that the approach that you'll be familiar with in terms of program essentials, things that are seen as priorities for just about any context, will continue. There are a few new program essentials, and I'll just highlight those. I'm not going to read through the entire list, but we do now have we recognizing the importance of sexually transmitted infections other than HIV, both as an entry door to HIV services, as well as an important area of service provision from the populations that we're serving. We've got a program essential on STI screening and treatment for people at increased risk of HIV. Going back to what I mentioned about the importance of focus on mortality reduction, we have a program essential around the new WHO guidance for the concurrent use of LF-LAM and molecular testing for people with advanced HIV disease to do better. The aim being to do better in terms of the identification of tuberculosis, pretty much the leading killer, along with serous bacterial infection of people with HIV. And then, in recognition of how prevalent sexual and gender-based violence is among the populations we support, and as well as the opportunities there to address an excess burden of HIV that is preventable, intimate partner violence, identification, first-line support and care, and post-rape care, we're recommending be integrated across the prevention, testing, and treatment cascade. So that's a very quick summary of where we are in terms of our GC8 prioritization guidance. There is a full version of this presentation available on websites, which I hope you have had a chance to look at or will soon be looking at. And I will stop there and look forward to any questions later in the Q&A. Thanks.
Thank you very much, Amir. We'll move now to Maria. Maria Fellan, which is the senior technical advisor for key populations at the Global Fund at the CRG KP team. Maria will discuss the planning and managing of HIV programs for and with key populations in GC8. Maria, please.
Thank you so much, and thank you all for the opportunity to discuss this today. And great to see so many familiar faces and new on this call. Maybe we can go to the first slide, please. So I'll talk to you a little bit about some of the changes in the modular framework that will be in relation to key populations for GC8, so that you're familiar with them. You'll be familiar with the modular framework already, and to an extent, much has not changed. However, I think what's important is to highlight where the key interventions are that you may wish to consider when you're thinking about planning and managing KP programming. So obviously HIV prevention and the HIV modules are the key areas where the modules for KP HIV programs are. The HIV prevention modules in the handbook have been streamlined. So previously, interventions were structured by key populations. So condoms for sex workers, MSM, people who use drugs, trans and gender diverse people, for example. Now the core prevention interventions, so condom prep, etc. Actually not prep, condoms and community mobilization, for example, are organized by key and vulnerable populations, which includes key populations and AGYW, as well as other vulnerable populations. We have a clear definition of key populations, which is aligned with the UNAIDS definitions and is stated both in the prioritization guidance and in the modular framework. What I think is important is population-specific programming has not been removed. Countries can still design and budget for tailored approaches by population. Target and delivery strategy can and should remain population-specific, and investments are expected to be aligned with the epidemiological context. As Amir mentioned, program essentials remain fully intact, with some new program essentials added. So program essentials around access to services, condoms, PrEP, harm reduction are there and are really important in this space. And indicators remain disaggregated by key population, both for visibility and accountability for outcomes for key populations. Safety and security, which is a really critical component of KP programming, is explicitly named under community mobilization and prevention stewardship in the HIV prevention modules, and in the RSSH modules under reducing human rights barriers to HIV, TB, and malaria services. And I just want to briefly touch on the human rights modules here, and then we'll go to the next slide to mention that the reducing human rights barriers and reducing gender vulnerability barriers, as you can see, to HIV, TB, and malaria services are now in the RSSH module. So what was there before under disease-specific modules is still within the modular framework, but it's been moved in order to allow both for cross-cutting interventions that cut across all diseases and have a longer-term point of view, and then those that can be disease-specific and can be incorporated into programming for key populations. Maybe we can go to the next slide, please. So just a little moment on the reducing human rights barriers piece, because I think it's quite important in relation to KP programming. As you can see, there's a cascaded approach starting with the minimum human rights standards in grant agreements, and then a dual track approach. So targeted programmatic interventions to address known barriers, so those early impact interventions, and then broader integrated interventions that can sustain quality and essential services for a long-term vision, all of which are working towards expanding access to quality and discrimination-free healthcare, improving health-related laws, regulations, and policies to enable access to HIV, TB, and malaria services, and improving legal literacy and legal support to health services. The human rights and gender modules, as I mentioned, are both cross-cutting investment areas for systems for health and disease-specific investment areas. As in GC7, disease-specific interventions to reduce human rights and gender barriers should be funded within the relevant disease grants and from those respective allocations. And only cross-cutting interventions should be included in the RSSH grant and split across. The placement of the human rights module under RSSH modular framework allows for more cross-cutting responses and strengthens consistency across different diseases. Human rights interventions have been streamlined into 3 interventions, but all GC7 interventions are captured within them. Nothing has been removed. So I won't go through everything on the slide as I'm aware of time, but as you can see, some of the implementation considerations are around moving beyond one-off activities towards more mature, comprehensive programs, strengthening local expertise for sustainability, ensuring complementarity with community systems, ensuring meaningful engagement, coordination, and oversight, through to integration of human rights programming in KVP differentiated services, as well as PHC and systems, and protecting the safety and security of health workers, community cadres, and service users, and strengthening multi-sectoral coordination, which is critical. We can move to the next slide. So I also wanted to talk a little bit about the priorities for GC8 for key populations. We have really worked in line with new guidance produced by the Global Prevention Coalition on managing and scaling key populations programs. We'll drop the link to that guidance in the chat because it's quite comprehensive and really supports budgeting and planning for KP programs using what is called a trusted access platform approach. So I think the priorities really are around protecting the coverage of essential HIV prevention services for key populations. And this may be, in some situations, given the tightening fiscal landscape, through identifying efficiencies through optimization or adaptation. And we'll talk about that a little bit more in a moment. It's important to continue to design programs for key populations based on this trusted access platform approach, which combines multiple service delivery models, from mobile clinics, structural interventions, pharmacies, peer outreach, safe spaces, to vending machines, in order to allow access for different communities, different populations in different modalities. Service delivery should be prioritized based on HIV incidence, so really where the needs are the greatest amongst key populations, as well as resource availability. And it may offer an opportunity to rethink underutilized service delivery approaches, for example, virtual approaches, which many communities are piloting or scaling. Perhaps there's opportunity to go further with those, with other populations, and where folks can access online services. Pharmacies, for example, or vending machines are other options that could be underutilized and may be suitable for some communities if they feel that this is a good way for them to access services. Wherever possible, supporting the integration of key populations into primary healthcare is important, but it's also critical to identify the potential risks in advance and implement appropriate strategies to address those. For example, developing planned and appropriate transition schedules, working on KP competent health units for key populations to ensure that the access is still there and that those units are able to meet the specific and differentiated needs of key populations within those settings. Next slide, please. So as I mentioned, there are some strategies to adapt to ensure that essential coverage, and this could be around optimization, adaptation, or integration. We can go to the next slide. For example, and I mentioned this this guidance at the beginning, and we'll drop it in the chat. But these strategies are based on the Global HIV Prevention Coalition guidance, and it's really around optimizing existing strategies employed by the program supporting key populations. So, for example, reviewing performance of outreach to ensure they're fit for purpose, reaching all those who need to reach it, and seeing where other services could perhaps be integrated or expanded further to ensure that coverage. Assessing cost effectiveness of strategies and using that trusted access platform approach, how different platforms can be utilized and leveraged to reach people to access services in different ways. Adaptation of the combination of service delivery strategies based on what resources are available, epidemiological considerations, ensuring that those who need the services most are able to access them and they're targeted appropriately for those populations. The human rights environment affecting access to HIV, TB, and malaria services is critical to consider in this. protecting coverage gains that have been made, and fully leveraging opportunities by potential new service delivery approaches, pharmacies, online services, and others. Knowledge of the local context will be key in adaptation. Communities bring that local contextual knowledge and have that first line response, understanding of what the barriers are to services and what adaptations would work for populations, and variations within any given key population category. This could be age, language, migration status, preferences for online or in-person services. I think that might be my last slide. Is that correct?
Yeah,
okay,
yeah.
I've given you a whistle-stop tour of a very large guide, which has a lot of detailed information in it. I really encourage you to read it and to look at it. We can answer questions, of course, but then do go away and have a look at it. And thanks again for the opportunity to speak to you all.
Thank you very much, Maria. Yeah, thank you very much for this summary. And thank you for Amir, for both of you, for this overview. We'll move now to the reflections from the global HIV networks, and we have with us Florence Anam, which is the co-executive director at the global network of people living with HIV, known as GNP+. We'll discuss with her the reflections from the global HIV networks regarding this. Florence, please.
It's an honor to join you, colleagues, today and to give reflections and perspectives of the global network of people living with HIV, GNP+. I will begin by reiterating that GNP+ is committed to securing universal access to treatment, viral suppression, and improved quality of life for all people living with HIV as the foundation for a people-centered, sustainable HIV response. This is something we've been doing for decades. GNP+ has led global efforts to center people living with HIV leadership in the dynamically evolving HIV response. We find ourselves in another period of evolution, transformation, if you will, with many changes currently happening within our funding landscape and transitions deeply happening within our service delivery spaces and platforms, something that many people living with HIV are experiencing as we go to access our treatment and monitor our care every day. I would like to share from what we did most recently, a report we shared in December that looked to identify the people living with HIV minimum requirements for integrated HIV services. We interviewed about 1,800 plus people, had some key informant interviews and focus group discussions to get the points at which people living with HIV feel are important for effective and responsive integrated services. This report outlines 7 non-negotiable minimum requirements for successfully integrating HIV services into primary healthcare and community health systems under universal health coverage. They reflect the priorities of people living with HIV themselves. I will just read quickly and I will put a link to the report on chat. Number 1, transformative participation. We should not lose sight on the importance of meaningful funded and decision-making roles for people living with HIV, people living with HIV networks, community-led organizations at every level. Number 2, context-specific models. Integration approaches that are adapted to local realities and the realities of service recipients are important rather than those that operate from a one-size-fits-all. Number 3, equity for diverse populations. Deliberate attention to key and vulnerable populations, including those facing multiple layers of marginalization. Number 4, comprehensive care, including management of comorbidities, mental health and psychosocial support, not just to access treatment, but to understand that people living with HIV and those impacted by HIV exist beyond just services and treatment. Number 5, resilient systems, having strong national health systems and community-based structures that can withstand shocks and transitions, learning from our unfortunate experience at the beginning of 2025. Number 6, stigma-free services that are safe, confidential, and rights-based in delivery of care. And finally, government-led financing, that sustainable domestic financing that protects and expands community-led services, while keeping to the ambition, and this is probably the most important part, of UHC, where the cost to treatment should not be a barrier to accessing services. As decades of investment in parallel HIV system have fractured, and financing shifts right now from adequacy alone to more like continuity, sovereignty, and transition, it is critical that the same is reflected, particularly in the planning of GC8, in securing firm community-based and community-led HIV services. We do understand that there are some unique differentiated service delivery models that have worked for the success of the HIV response and are important in the community support structures. Aspects of adherence counseling, mentor-mother programs for PMTCT, identification of people with advanced HIV disease, post-discharge care, among others, have been useful to getting us to where we are. We must protect and strengthen them in order to sustain the gains we have made and realize the 2030 goals and a true HIV epidemic control. At GNP+, we believe the ambition of HIV epidemic control is possible. We have the scientific opportunities currently and in the future to make this a reality. To be successful, we must be committed to preventing advanced HIV disease and ending AIDS mortality, particularly using the powerful community message of U equals U, and double down on prevention to end new HIV infections. The breakthrough in long-acting HIV prevention we are experiencing now, in particular the injectable LEN, gives promise to the innovation for long-acting oral and injectable HIV treatment that I believe is good news and such a game changer in the coming years that will serve many people living with HIV for whom the pill burden continues to be a barrier to achieving viral suppression. We are promising to collaborate with you all, but call on all the people on this call, all partners, governments, funders gathered today to adopt and implement these 7 people living with HIV minimum standards or requirements as a benchmark for ensuring responsive HIV service integration for all people living with HIV in the GC8 era that is evolving rapidly from a parallel system to a more integrated health service delivery system. I wish you all the best with this call and with the work that is happening at country level. Thank you so much, and back to you.
Thank you. Thank you very much, Florence, for your input. Now, within the same frame and the reflections from the global HIV networks, we have with us Anil Padavatan, which is the health lead at GATE. Anil will discuss with us community reflections and priorities. Aline, I'm going to share the screen for your presentation.
Thanks so much. Perfect. So thank you so much. It's great to be here with everyone today. I'm joining you from South Africa, where it's a cloudy, rainy day. I hope everything is well where you are in the world. Next slide, please. So I'm going to start off with some reflections on where we're at, and first of all, what's changed in Grant Cycle 8. And as we all know, the context has changed significantly. We have reduced donor funding, which has resulted in strategic shifts, which have created opportunities, but also some significant risks for community-led responses. And we're also at the moment in the context where we have much tighter timelines for Grant Cycle 8, and we have the late publication of the revised guidance documents, which does present additional challenges for community participation, especially in countries applying in Window 1. And in this context, community guidance and community-produced documents become increasingly important. And I'm going to be speaking and referencing a particular community guide today, the Joint Communities Guide, which was developed by GATE in collaboration with Impact, Input, NSWP, and Y Plus Global. And I'm putting the link for that in the chat. Next slide, please. So following that, let's have a quick look at what hasn't changed, because that's also very important. So what has not changed is the Global Fund's policies and strategies, including the commitment to human rights-based programming and placing communities at the center. And another thing that has not changed is the implementation science, because we might have less funding, but we have decades of very rich data that shows us what works and what doesn't work. We know that differentiated service delivery, interventions that address underlying drivers, and community-led initiatives are really key to effective disease responses. We also know that tailored programs that focus on specific communities offer better value for money than a one-size-fits-all approach. And we know that choice improves uptake. And critically, we know that community-led interventions are highly effective in reaching marginalized populations. Next slide, please. So in this context of having less funding available, we really don't have any money to waste on programming that is not effective. Cost effective consists of two elements, cost and effectiveness. And we really need to look at what is effective, and community-led organizations and community activists need to be well prepared with all of the data that they need to show the effectiveness of the community responses and community priorities. GC8 does provide us with some important opportunities. First of all, there's the community annex, which is now compulsory in some portfolios, and that's a very, very important tool. We also have an increased emphasis on community systems financing, and this is very important because we need to make sure that as we are shifting towards increased domestic financing, we're protecting community and strengthening community systems. And we need to be ready with the data to show that community systems are not a nice to have, they're not an added extra, they're really essential for results. In terms of the shifts of a greater focus on integration and sustainability, this gives us an opportunity to embed community roles inside core program designs. And with the greater emphasis on transition, especially in countries that are on an accelerated transition pathway, it's really essential that we start looking early at options for sustaining community-led programming. There's a lot of emphasis on the moment at social contracting. Social contracting is one pathway for community sustainability. What we know is that in many countries, for social contracting to be implemented, it requires a change in law and policy in the fiscal, legal, and policy frameworks in many countries. And it will also, in some countries, require the repealing of criminalization legislation. And law and policy change, we know, takes time. It can sometimes take many years. So it's very important that we also look at other pathways for sustaining community systems, including social entrepreneurship and direct funding, especially in criminalized contexts. Thanks. Next slide, please. I'm not going to go through the next slides in a lot of detail because you all can have a look at the Joint Communities Guide, where this is all set out in a lot more detail. Just going to go through the community priorities that are captured in the guide by the global key population networks. So for the trans and gender diverse community, priorities include dedicated budget lines for trans-led services, an increasing focus on peer-led interventions as highly effective in reaching the trans and gender diverse community. We also need training to ensure trans-competent and gender-affirming health service provision, especially when we're looking at integration into primary healthcare facilities. We need legal literacies responses and violence responses, especially for community members who are experiencing gender-based violence. We need community-led monitoring as an essential accountability tool. And we also need transition plans that protect services for trans and gender diverse persons as we shift towards domestic funding. Next slide, please. For the gay, bisexual, and men have sex with men communities, priorities include maintaining community-led services, especially in context where there's high levels of stigma and discrimination and criminalization. Strengthening community-led systems, equitable access for gay, bisexual, and men who have sex with men to new prevention technologies, and ensuring that disease integration does not cut services focused on gay, bisexual, and men who have sex with men. Next slide, please. For the sex work community, priorities include sustained funding for essential commodities for sex workers, especially condoms and lube. And as we're looking at the introduction of new modalities for prevention, we should not ignore condoms as a pillar for the prevention initiatives. We need to prioritize differentiated community-led services, which are in resource-constrained settings. We need to invest in interventions that address stigma, discrimination, violence, and criminalization, and other barriers. We need to ensure that sex workers are explicitly reflected in national targets and indicators. Strengthening community systems and leadership is very important for safeguarding continuity of services. And we also need to position community-led monitoring data as vital evidence for programming and resource allocation. Next slide, please. These are some priorities for people who use drugs. There's more detail in the guides that I've shared in the chat. Priorities include maintaining harm reduction in the package of services, ensuring equitable access to medically assisted treatment, including opioid agonist treatment, ensuring gender responsive services for women who use drugs, increasing accessibility of naloxone, reducing human rights related barriers, increasing access to funding for drug user-led organizations and networks, including program management costs as eligible expenses. This is very important. And instituting social contracting where in settings where it is possible. But also we need to continue to push for direct funding mechanisms for communities in criminalized and other hostile environments where social contracting will not be possible. And we also need to safeguard strong, well-funded, community-led data collection. Thank you so much. Sorry, I've got one last slide. Key priorities for youth. So for these priorities include formal representation of youth and participation in CCMs, dedicated and equitable funding for youth-led organizations, an increased focus on youth-led monitoring, capacity strengthening for effective participation, and the inclusion of youth engagement that includes intersectional realities and is inclusive of rural youth, young people living with HIV, young key populations, LGBTQI youth, and youth with disabilities. Thank you very much, and I will be very happy to take questions in the Q&A section. Thank you all.
Thank you very much, Anil, and this was really a very nice presentation. We'll move now to the Q&A section. So if you have any questions that you would like to raise, please feel free to raise your hand or go into the Q&A section within the webinar. Please, if you have any questions for Amir, Maria, Florence, or Anil, just go ahead and feel free to ask your questions. I see that we have one hand raised from Sarah. Please feel free to unmute yourself. and ask your question. Until we do
Hello,
that,
sorry, I have
yeah,
a
please go ahead.
problem with the computer. I'm
Okay.
trying to, sorry.
That's okay, no worries at all.
Thank you.
Okay, so we have 2 questions in the Q&A already answered, but I'll go through them quickly until we have any questions. So we had questions for what does program essential as a framework for prioritizing practically mean? Does it mean Global Fund will fund areas of program essentials as a priority? And Amir does reply with, it defines the core interventions need in most settings for HIV impact. We would look to see there are adequately covered and to seek clarification if not. Inclusion as a program essential does not necessarily guarantee financing in preference to other options for investment. Okay, and then we have a question from Gabriel on integrated services purposes that key populations programs are offered with the context existing public health facilities who are expectedly empowered and capacitated to be KP friendly. Does this emerging modules truly guarantee the KP programs? And we have a response from Matteo. Okay, so just before we get to Matthew's answer, Florence is here for 3 more minutes before she has to jump out to another webinar. So if you have any questions to her, please just go ahead. In the meantime, Matteo's answer would be you're correct. One dimension of integrating key population programs into wider primary healthcare services involves increasingly relying of public health facilities to provide services to KPs. In GC8, it will be key for KP programs to include investments to support public health facilities to provide care that's KP competent, respecting of privacy and confidentiality and non-stigmatizing. It will be also critical to ensure that community-led monitoring activities routinely check the effective quality of services offered to KPs at health facility level. It's, however, important to note that integration of KP services into primary healthcare does not mean stopping the provision of services at the community level. Depending on the context and on the type of human rights environment in which KP programs are implemented, it will be key to preserve the availability of services to KPs at the community level. So thank you for the questions and thank you for answering that, Matteo and Amir. So let us see if we have any other questions before moving on to the second section. We have a question from Nadia. A question related to HIV integration into primary health stigma still exists. And okay, so that was the question in the Q&A. Okay, so if no more questions, we'll go on to our next session, which is a panel discussion on building stronger and sustainable HIV responses to achieve national targets. What are the best practices and the lessons learned from the GCA7 HIV grants that could be used to guide community engagement and advocacy in GC8 programs to design? We have 3 speakers with us. We'll be starting with Rui from Mozambique. Rui will be talking in Portuguese. So if you'd like to join the English channel, this is for you. Rui Senda, he's the Senior HIV Prevention Officer for Key Populations, and we're going to discuss the good practice in adopting key population programs in Mozambique. Rui, the floor is yours.
Bom dia.
Morning.
My name is Rui
I'm
Senda.
Rui Senda. I
I'm
work
a
in
senior
prevention
officer
of
for
HIV
HIV
for populations of
and
the FDC, main
a
receiver of
primary
the Global
recipient.
Fund for Integration in the community. So we will
So I'm going to
talk
speak
about
here a
what
little bit about the experience of our program,
has given
which
us
is Viva Mais,
in this
in our response
response
to
to
HIV in Mozambique. We'll speak
We'll
about
tell
good
you
practices
about the
that we
good
have
practices that we have implemented
as
and
well
also the
as
programmatic challenges
program
that
challenges that we
we
have
have
faced,
found in the
as well
response
as
process,
the visions
as well as the
that we have
visions
as a
that we
country
have as a country
in
for
terms of
GS8.
GC8. So
Briefly,
briefly, I will
I
do
will
some of the explaining
explain
of what is the
what
program
the
of
program
Viva
Viva
Mais,
Mais is. That's the name of our
which is
program
led
that will be led by
our
FDC,
our
which is our
main partner.
It's a program
It is
for
mostly a program
communication and
for
behavioral
behavior
change
change
for
in
HIV
terms of HIV
prevention
at
at
community
community
level.
level.
And this
And this
program
program
includes
integrates
services for
prevention
prevention
services that are
at
combined
community
at
level.
the community level.
We
We
offer
offer a set of services ranging
a series
from
of services
communication
that
for
includes
behavioral change,
communications on behavior change, community testing, self-testing. We also talk about we distribute
condoms, lube, and other
paraphernalia for people who take
implements for people who use
drugs. We
drugs.
also distribute prevention. We
We
also do
trace
screening
TB
for
and
tuberculosis,
other
and we also
diseases in the community.
we direct suspect cases for laboratory testing at the level of health facilities. For people who are already affected, we also do testing for HIV for hepatitis B and C. We also do the redirecting of people that have had negative results to do PrEP at community testing, so they can start doing PrEP at community health facility level. So yesterday was the launch day for the for lenacapavir in Mozambique. We are also still mobilizing for testing for PrEP, and we are also going to carry on when the vaginal ring is available. So our focus is towards combined approaches in a systematic way. So that means we have an approach for individual treatment, so that we have a dialogue with and communication relating to HIV in terms of access to services and human rights, so that individuals can have the necessary competences for prevention, and we do the necessary support. And we also do community testing, immediate community testing for individuals that are part of the program. So these people on the program, they have a specific code that has been given to them. They are registered on a platform on the DHIS2 with all the information of the services that this individual receives and has access to. And so it is possible to have all the information that is provided to this individual. So from this moment onwards, that the moment that the individual is registered, so he will start receiving all these combined services. So we do a risk assessment to determine the level. We've lost Rui. To determine the level of services that this individual needs. So these populations also receive literacy on human rights, so that they know. So the community literacy, so that they can also create a favorable environment for response of their communities. We also do literacy amongst the health workers at rural facilities, so that they can also improve their treatment of the key populations. We also do the identification of violations of human rights in all of these places. so that such cases can then be forwarded to the competent authorities, and we follow up until each case has been resolved. This to guarantee the rights on behalf of key populations. Every 3 months, or depending on what is the necessary by the beneficiary or recipient, we do a follow-up of the services to ensure that all the needs are being taken care of for specific recipient. For example, condoms are made available according to the needs of the recipient in terms of his frequency of activity. So over a month, it is possible for this individual to receive condoms according to his specific needs. So our peer educators are in the community and frequently make available and record these supplies, and this allows us to see in a comprehensive manner the volume of services that is being delivered, and whether we are under offering or under offering services, and whether it is being offered in an integrated fashion. We also do an assessment of risks, of intermediate risks, to see the trends in behavior improvement of the risks compared to the point at which the individual was registered into the program. And then we also do every 6 months, or whenever there's a high risk before the 6 months, we also do a follow-up testing to be able to have data on trends of improvements and for exposure to HIV. So this frequency of testing of every 3 months has allowed us to measure the quality of the interventions, because the positivity trends has been going down for those who have been longest in the program compared to people who are new to the program. In terms of to PIBs, we are working on a package of all the services, including replacement of therapies. So also for people who need different therapies, they are then directed to specific centers. But the vision is to broaden these services, which are now available only at 4 centers. We are going to broaden that to different other cities, and also for harm reduction. So for those receiving, for those receiving the whole package of combined services, we also have then specific cases for those people who inject drugs, and we still have barriers in terms of providing injections and syringes. But we are doing a very comprehensive advocacy work to open this space to make available needles and syringes, as well as at a number of health facilities. So looking at this in a more comprehensive way, our program from 2024 to 2025, so over 2 years, our target of the people was 68,000, and this represents around 35 to 40% of the estimate of key populations that we have in the country, which is about 190,000. So we had a target of reaching about 36% of the key population, and we managed to, in general terms, to involve 99% of our target. Some groups in the key populations we managed to recover, but we still have challenges in specific groups like the transgender people and prisoners. So the transgender being a new group in the country in terms of HIV prevention, we started only in 2024. And almost towards the end of the second semester, so we didn't have a very successful performance, but we are making efforts, and these groups are still not very visible in the country. So we are trying to improve our penetration in these two groups through organizations of LGBT communities that better can exploit or utilize their networks to reach these populations, because many of these people do not come forward or do not want to identify themselves. But we are doing everything that we can to ensure that we are able to reach all these populations. And another gap that we have in terms of the transgender is a geographical challenge. So we are active in 13 districts, and not all 161 districts. So only 65% of these districts are involved in programs for transgender people. So this is another gap in our service provision. In terms of positivity for new key populations integrated into services of our Viva Mais program, we have a high rate of positivity, similar to the one that has been identified for the national HIV program in all their testing of key populations, which varies from between 5 and 9%, with an average of about 7% of new populations integrated into the program. But along our testing, we have been able to see a trend of a high reduction because of our personalized services, of our combined services. In terms of we have a high level of satisfaction, average of 94% of people tested in community are able to get integrated into local health units. We have very great challenges in terms of PrEP. So the number of individuals that test positive in the community to go to a health facility to start PrEP, we still have very low levels, so between 40-50% on average of individuals that accept the possibility of doing PrEP. But of these individuals, only about 80% then reported to facilities to start PrEP. So the big challenge relies in accepting oral PrEP, which varies between 40 and 50% of people with negative results. And then only 80% then eventually report at health facilities. But the challenge remains, because even those who are already on the program, they tend to have an acceptance level even lower, between 10-15%, So there's a need to improve other approaches to PrEP within GC8. Maybe there's a need to diversify the modalities of services to improve even more the level of acceptance and to these new prophylactics. From the point of view of what we've identified as challenges, besides the ones that I've mentioned, we also have uh, so in terms of opportunities of what we can do to improve our performance in the new grain cycle, one of the issues that we've identified is within the systems of monitoring. We need to improve our mapping system using program data to have more robust estimates that will allow us to better map the areas in which we must carry out our services for prevention. So for some areas we have estimates that do not match the mapping that we are using in our implementation. We also need to standardize a single number for individuals within the health services for key populations. Another thing that is also opportunity is program integration. We'd like to use our community health workers to improve their profile in terms of service offer. So we want to improve tuberculosis screening, but also to look at other opportunities for programs supported by the Global Fund, such as malaria, to see if these community health workers can also carry out literacy for malaria and other services. We also want to ensure the issue of follow-up consultations for prenatal or antenatal for key populations, so that we can also do follow-up of prenatal or antenatal consultations and follow-up of the fetus or the child after birth. In terms of other activity, we would like to cross over with our community health workers. They work with the public services that offer other services in primary health that can be integrated in the role of the activists and community health workers and activists to be able to offer broader services in the community for these specific groups as well as connected groups, including following up of tuberculosis cases, testing of index cases of people amongst the key populations, and other services, complementary services that can be integrated to maximize the role of the community health worker. So I believe I can stop here, and thank you very much.
Input. Now we'll move on to Arlerta and Lela, who's currently providing oversight for a 3-year HIV prevention project funded by the Global Fund, so we can discuss with each other about the LEN introduction in Swatini. Arlerta, the floor is yours, and you'll be having 6 minutes to 7 minutes. Please feel free to go. Arlerta, can you hear us? Yes. Check, check. We can't hear you. Okay, as Arlerta, yeah. We can see your screen, but we can't hear you yet. And for all the participants, Arlerta will be speaking in English, so if you'd like to go back to the original channel. Arlerta, we can't hear you. If you want, we can move to Nadia while you fix the audio thing, if you want to. Okay, Nadia, could you please go
Hello.
ahead? Yes. Hello.
Oh, can you hear me now?
Yeah, we can hear you now. Okay, Nadia, sorry, we'll go back to the original schedule. So, Arlerta, the floor is yours for a 6 minutes presentation on the LAN presentation, LAN introduction in Swatini.
Thank you so much. I'm happy to share experiences of introducing Lena Kapave in Eswatini. I've just mentioned my name is Aleta Ndlela. With the Coordinating Assembly of Non-Governmental Organizations in Eswatini, who is the umbrella body for civil society organizations and is responsible for coordination of civil society, building capacity, advocacy, as well as grants management for civil society grassroots organizations. So in our role as the principal recipient of the Global Fund for Civil Society organizations and programs, we also work on a lot of capacity building as well as advocacy. So as we implement the Global Fund HIV prevention program, we were a part of the Lena Kapave PrEP introduction in Eswatini. I'm not sure if many of you may know, but I'd like just to share that Eswatini is a country in the southern part of Africa, around 1.1 million people. And we have had a progress in our HIV response since we have managed to really improve in terms of reducing our HIV incidence. Between 2017 and 2021, we moved our HIV incidence, reduced it from 1.13% to 0.62%. However, we still remain with a prevalence of around 24.8% of people living with HIV in the country. So we have made extreme progress in terms of improving the HIV response as one of the countries that have met the UNAIDS ambitious targets. However, we continue to experience continued infections among different subpopulations. And we have adolescent girls and young people, as well as key populations as well as subpopulations that continue to experience increased HIV infections among those populations. So I'd like just to take you through what we have done As part of the response to the HIV prevention efforts, Eswatini is one of the countries that received and introduced lenacapavir in December 2025. It was a very big has been progressively trying to respond to reducing HIV infections, as I've mentioned a little bit on the statistics of our HIV response. However, lenacapavir came in as a game changer globally, and for us, even in Eswatini, it came up as a game changer. So we initially received 500 doses in November through the support from the Global Fund and the partnership with Gilead. And it was officially launched by our Honorable Prime Minister in December 1st on World AIDS Day. So as we prepare for the GC8 discussions, we'd love to maybe just highlight our role as civil society in the
Oh, we cannot hear Aletta, and I think Amjad is also speaking. We can hear you. So apparently we have lost Arleta. Okay, so instead of waiting, we'll move to Nadia, and when Arleta is back, we can go back to her final slides. Nadia, please go ahead. Nadia Badran is the executive director at SIDC. We'll discuss with her integrating human rights, gender, and community engagement to reach disease outcomes in Lebanon. Nadia, please go ahead.
Yes, thank you, Amjad, and thank you all for this opportunity. So I'm representing SIDC. It's a local NGO based in Beirut, and we work for the past 36 years now with key population on the same topics. So when it comes to integrating human rights into HIV/AIDS response, like all of the past speakers now, they talk about gender vulnerability, they talked about human rights, legal awareness, stigma and discrimination, advocacy to reduce stigma and discrimination. So when we talk about integrating human rights in HIV and what we are doing, it's that we put the human rights at the core foundation of any HIV programming. And this, like, if we can look at the human rights from this perspective, we can see it as a mean for us to increase the access of people to free services from stigma, from discrimination, from oppression, and also it will help people to start their medication, to access testing, and to stay in care. So the retention in care, it can be also affected if human rights is not tackled. And how we are doing there, we are implementing REACT approach. The REACT that help us as civil society to track violations and to document these violations happening with key population at different levels, not only when accessing services. And when we are documenting this violation, we are extracting like what could be done at the level of legal literacy, for example, for key population, but also what information we can use to do more advocacy. And this is why in our interventions now, and this intervention were part of a global fund programs in our country. So we are raising awareness or empowering people to be part of the community-led monitoring of the accountability, and also they are more involved in advocacy activities. Like, for example, I will give an example about the development of the advocacy strategy when it comes to OAT treatment. Also, when it comes to stigma and discrimination law development and presentation of this law and the discussion around it with all stakeholders. And also when we are tackling stigma at healthcare setting, when we are working with media, with religious agents, with police on developing specific module to tackle stigma, and also when we are developing policies that would help us also to protect people when they are accessing services. And also to retain them in care. And why I'm talking about that, because if also I want to answer the gender part in this discussion, I would stress on the importance of gender responsive approaches and to improve effectiveness of the services. And here, where we are as civil society, we are integrating protection, health together and the human rights there, so the people have access to information and to legal literacy in part, but also in all protection services when they are facing any abuse related to gender or also to any kind of inequalities, to reduce their vulnerability and to ensure the equity in access to services, to prevention and care services. And also, if I'm talking about the community engagement to reach the disease outcome, the 95, we are looking at the community at the core of any intervention. Intervention related to advocacy, intervention related to service delivery, and this is where we talk about all the experience that we have in implementing community-led services and differentiated HIV services, not only in testing, in awareness, in outreach, in online outreach, in using mobile app, in implementing, for example, the Ask Me app for people living with HIV, the Hype app for others, and the awareness raising on the dating app for key population. So all this community-led digital awareness, it is also we're part of it, of Global Fund programs, and we are also keen to see them more in the GC8, and this was very clear when Maria was presenting. So we will find also this kind of activities where we can when we can improve our services or ensure the continuity or the sustainability of these services. And also, like things that I can share can be related also to harm reduction, to how we can not deliver the service, because in the Global Fund we are not delivering services, but the complementarity between MER in our region and the Global Fund, it helped us throughout these years, and now also for the next year, it will help us to ensure the service packages are aligned with gender, with the human rights, and will help us to reach 95, and to ensure equity in the service delivery or service accessibility and linkage to care, because retention in care, it has been also more and more important. And this is where, for example, in the Global Fund, the programs, we were able to establish, for example, more strategic intervention when we are talking about social contracting or with involving private sector for resource mobilization. So all of this has a gender lens, has a human rights lens, and also it will help us to sustain our services as well. And also one more example, for example, Amjad, it's about the establishment of this multi-sectoral stakeholder committee, because in Lebanon, for example, we don't have CCNs. Throughout also the support from Global Fund and also complementarity with MER, we are able to have in place this multi-stakeholder representation where the communities are members of this platform, and where they can express their needs, and they can also reflect on all the challenges that they have in different level when they are accessing services, or when they're accessing a dignity life between brackets. So all of this are important. And one more example, if I may, it's about intervention inside the prisons. Because the prisoners, and when we are talking about harm reduction, all of this, it's very much challenging in a prison setting with the laws, with all what is happening in Lebanon, not only stigma and discrimination, but lack of resources, etc. So if we have and this is an opportunity now that we are doing under the Global Fund, it's to develop a minimum package of care on harm reduction and HIV in a prison setting. And this will help us also to start strategically thinking how we can embed more services and comprehensive packages for the inmates. And this is also in a lens of a community-led or community experience, because the communities are at the core of development of these module, of these manuals. If I can, I will end with some things around the challenges. For example, the big challenge in Lebanon and in other countries, it is the emergency and the humanitarian I don't know how environment that we are working in, and where HIV it's not a priority, it's not advocacy, it's not a priority, and this is where we as a community organization, we are trying our best to lobby and to advocate for the needs and to integrate HIV in the humanitarian programs and into protection programs. And this is how we are able to sustain some of the services or some of the activities. Also, we talk all the time about the structural barriers when it comes to legal environment, to laws, to stigma, to discrimination that is embedded in the culture. And when you have refugees, when you have migrants, when you have people with diversities, so you can imagine the big stigma or the level of stigma that these people can endure. And also we are till now trying with the support of the Global Fund to build the trust with the government, with the institution, with primary healthcare services, in case we are into going through, because all globally they are asking us integrate, but we should think and have time to think what to integrate and what we cannot integrate until now, in order also to respond better to this 95. I will stop here because I'm not sure because of the time, but I will stop here, and thank you for this opportunity again.
Thank you, Nadia, very much. This was very helpful and very interesting. Okay, so we have Arlerta back. Arlerta, so please go ahead, just to wrap up on the LEN intervention within Eswatini.
Okay, thank you so much, and apologies for the internet interruption. But I would just like to wrap up with saying as a way of ensuring a meaningful contribution into land rollout by the communities, I would recommend, based on what we have done in the country, for active participation of communities and civil society into the national technical working groups to ensure that the review of the guidelines to integrate land prep is aligned with the needs of the communities, so that communities are able to contribute to the selection of sites for where rollout is. And that is very important to ensure that the sites that are selected for implementation of the rollout are the sites that are youth friendly, sites that are key populations friendly, as I believe that most countries are also facing the same challenges that Eswatini is facing, where most of the key population specific clinics that were supported by USG have not been opened as yet. So we need facilities that are friendly to young people as well as key populations. And also active involvement in the development of messages, as human rights is one of the issues that we need to integrate as civil society, so that the messages that we are sending out on PrEP are not stigmatizing, and are messages that are empowering and encouraging and building agency for our young people and the vulnerable populations. So as we mobilize for PrEP, I think it becomes important too, as communities, to prioritize HIV prevention as a package, not only land PrEP, but the different forms of PrEP that are available in the countries. Because I think in as much as we have this groundbreaking commodities, we are aware of the realities of the supply issues. Hence, we always need to be engaging on PrEP rollout as one of the pillars of prevention packages, and I'm sure that will actually meet the needs of of us to actually integrate services as well as highlight as well as prioritize prevention as a bigger option for 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 our populations. So I would just encourage as we go out to GC8 to really look into those, as they could be enablers in ensuring that the land prep rollout is more structured and is informed by the communities and the voices of the communities. I thank you.
Thank you very much. Thank you very much, Alerta, and sorry for the technical issues. We'll move now to our last intervention from Pedro. Pedro Trinidad, who's the technical advisor at the community engagement at the Global Fund, to discuss tools and resources for community engagement in GC8. Pedro, these are your slides.
Yes, thank you, Amjad, and thank you, everyone. It's nice to have this opportunity, and thank you for sticking until the end. My name is Pedro Trinidad. I'm a technical advisor at the Community Engagement Strategic Initiative. And we wanted to go through some of the key tools and resources that are available for support in terms of engaging with GC8 Global Fund and country processes. So if you go to the next slide, Amjad. So we've heard different examples of the key importance of community engagement throughout this morning's webinar. So in terms of support of what the strategic initiative can support and is supporting already, we have what we call short-term TA, which is a mechanism that allows us to deploy around 20 to 30 expert days, depending on the country and on how many grants there are in the country, Global Fund grants. And the TA can support communities and cover in different types of support during funding request development and during grant making. So for example, during funding request development, it can support maybe a rapid review of Global Fund grants, previous Global Fund grants, so that communities have a little bit of more data in terms of maybe what worked well, what didn't work well, and other lessons learned, maybe from GC7, from previous funding requests, from GC7 reprioritization, or from other sources of data. So it can support also desk review around similar topics. It can also support priority setting for communities. So in many countries, the strategic initiative has supported prioritization consultations with communities, with civil society members, that they for communities to come together and to really discuss and align on some of the priorities, particularly ahead of the national dialogues, when the Global Fund grants will be discussed with other country stakeholders. So it's really an opportunity for communities to come together and to discuss and agree on having a common front in terms of deciding priorities. It can also include, for example, support for costing these priorities, so that that communities can also come with stronger costing arguments, which is particularly now relevant around discussions of efficiency. Support through grant making processes is also available. So during grant making, support can involve, for example, mentorship to communities during grant making discussions, so that they have better maybe access to information or can strategize during this important process. And it can also support, for example, small short briefings around the grant making outcomes, because a lot of some of the shortcomings that we've heard is that communities at the end of grant making don't really know what the outcomes were. So this is also a support that can be requested. So how to request the TA, I will not go in detail, but just to highlight that it's important that it's well aligned with CCM, civil society, and community representatives, and that your learning hubs, or the learning hubs in your region, should be able to assist you in sending you the TA form, but also helping you to fill it out. And then all countries eligible to GC8 funding can apply. However, though, Windows 1 and Windows 2, we are not, applications are now closed because it's too short. There wouldn't be time to mobilize the TA. So really for Windows 3 and next Windows, just make sure that you are submitting at least 6 months before the GC8 submission window. Next slide. The initiative, there is also what we call the rapid engagement support. And this is very similar support, but just a little bit of a lower scale. So it's up to $5,000 US, and the support is provided directly by the learning hubs. So support can be similar around virtual or face-to-face consultations, around community participation in decision-making meetings. So like in CCM, in writing retreats, or in other processes related to GC8. And then the support can contract consultants to review documents for a short, to facilitate a community consultation, or to provide virtual mentorship. Again, important that they are aligned with CCM, civil society, and community representatives, that CCM Secretariat is aware, and that this is really in line with the timeline that the CCM is looking into for GC8. So again, reach out to your learning hub in your region. Next slide, please. And in the chat, my colleague Annabelle is dropping some of the support that is already ongoing in countries. So if you see the list in countries in your country listed there, don't hesitate to reach out to the email that is there to make sure that you're also involved in these processes. One short slide around contacts for your regional learning hubs. A little bit of a promo, join the newsletters. They really have some of the key information around GC8 processes. So join the newsletters if you haven't, and you have the host organization, as well as the focal point there for you to contact and reach out for any questions or assistance. Next slide. An important resource, the Community Engagement Toolbox, that will be updated in April 2026, and a tool where you have a lot of the resources that have been developed by our Community Engagement Strategic Initiative. And because there are many resources, many things happening here and there. This resource is really an effort to put everything that's out there, or many things that are out there that are developed by partners, put them in one place, and you can then find yourself easily with that. So you have resources around basic understanding of the Global Fund, up to more maybe more technical around assessing or evaluating community engagement, around accessing technical assistance, engagement in country dialogue, in grant making, etc. So that will be updated in April 2026, so later this month. So stay updated. Yes, next slide. And other updates that will also be available soon, that will be also integrated in the toolbox once it's updated. So we already discussed, Anil already made a great presentation around what we call the summary presentation, or this summary slides on what communities must know about GC8. So that was led by GATE, but in partnership with KP Networks and other global networks. And then other key resources that are coming up around costing, around organizing community consultations, around service integration, sustainability and transition, and community guide on RSSH. So this will be in the toolbox update. And with that, stay in touch. Thank you all. And back to you, Amjad. Thank you.
Thank you very much, Pedro. This was very clear and concise. Thank you very much. With that, our webinar comes to an end. From the Mena Learning Hub and all the other learning hubs across the globe, we would like to say thank you for being part of this. We would like to say thank you for all the presenters today and all the speakers. It was really nice to have you on a very important topic, specifically focusing on the HIV guidance, the GC8 HIV guidance. So thank you for that. And also, I would like to thank Talin and all the other colleagues at the learning hubs to put all these efforts that they have put in the very short time just to make this happen. Please make sure that all the recordings and all the PowerPoints shared will be available and will be sent them through the email if you have already registered and if you have already shared your email through the chat. Thank you very much, and see you soon, hopefully.